for the kind introduction, and thanks JPEF team for inviting me here. It's really a tough ask to talk after lunch because we all have our glycemic surges which clouds our brain, and it is really difficult, I can understand. So the topic is a future of smart insulin, because insulin itself is not new, not dumb, but now we are looking at smarter insulins and we are talking beyond pumps and pens. So I will not be talking about any pump or any pen in this talk. So this is all futuristic. This will like be a M. Night Shyamalan movie, because whatever I am going to talk is not on field yet, but it will soon come, like anything which we discussed 10 years back has come. I have no financial disclosures for this talk, nothing to disclose. So we all know that managing diabetes is a very tightrope walk for us, especially we physicians, clinicians, diabetologists, endocrinologists, because we are always worried about hyperglycemia on one end and hypoglycemia on another, because we are always worried that our patient should not land up into a bad hypo, because that will take our patient away from us. He will never come back to us after a bad hypo. Especially hyperglycemia, although it may look good initially to have a little bit of hyperglycemia, but in long run our patient will suffer from all the complications which we talk about. So this is a tightrope walk, and this we all face each and every day. We all have known from history that managing diabetes in a tighter way is very important, because the tighter the control, the best is the outcome. The closer the HbA1c is to 6.5 and 7, the better the outcome in terms of complication. We all know about this. So this again becomes difficult for us to manage without going to hyperglycemia and without having hypoglycemia as well. We all know about insulin. This is how insulin was discovered more than 100 years back, and this was the first patient, JL. On December 15, 1922, he was given insulin, and see, in just 2 months, he again became a chubby baby. Now again, this is how the injection therapy feels. We all talk about insulin, but taking insulin itself a pain to most of the patients, because most of the patient cannot afford pump. It is difficult to manage and cumbersome in cost also. And again, the pump therapy is not for everyone. So a type 1 needs to take 1460 shots a year to stay alive. Now again, we all know that 31 million Indians face insulin challenges due to high cost, hypoglycemia and poor glycemic control. They all are facing this challenge. So what if insulin could think, respond and adopt automatically without you need to do anything? I am fortunate to have two of my co-authors here sitting with me, Vipul and Dhruvi. We did this piece of work few years back, and this was a revelation for us also, because we found that most of the clinicians don't initiate insulin due to fear of patient running away or hypoglycemia. Once even doctor prescribes, the patient doesn't take it due to fear of pricks and hypoglycemia. So this is a beautiful read. If you ever get time, go and read this. This will change the way you practice regarding insulin and diabetology. This is again how the whole journey of insulin started, and now we have come to a place where we are having fully automatic pumps in our hand and they work on their own. And this is a journey which should be remembered for years, because we have come from pricks, multiple pricks and bovine insulin, now up to analogs and pumps. So now why smart insulin matters today? Coming back to the topic which is in my hand, because we have a decision burden. 180 plus daily decisions a type 1 diabetic need to take regarding food, insulin, exercise, other things. They burn out eventually. Data shows 73% of them burn out, and 55% have at one point of time nocturnal hypoglycemia. 65% miss doses due to rural travel barriers, and 23% due to cold chain failures put insulin which is not effective. The smart solution actually, which is glucose sensitive insulin, that is their oral and weekly insulin, they are emerging due to all these constraints which are there with insulin. Now what is the 3P framework for smart insulin technologies? It simply runs on a 3P formula, which is predict, prevent and personalize. By predict, it means glucose sensing insulin, which can sense insulin. It can predict the rise in glucose and act accordingly. It can prevent hypoglycemia by autoregulation. And it can personalize the individual needs of the patient, and it can help in the lifestyle dosing, because lifestyle keeps on changing and we cannot keep giving insulin for every event which is occurring in our body. So it can personalize the treatment for them. Now again, there are simple examples. This is Sensulin's GRI, which is glucose responsive insulin, which can predict and actually activates at more than 180 milligram per deciliter of blood glucose, remain dormant when it is less than 120. So this is phenomenal. If it comes, then nothing to worry about. You can put any dose you want, and you need not calculate, even patient need not calculate, and it will be OTC, I think. Prevent auto hypoglycemia protection, the zero insulin activity at less than 100. So insulin become almost dormant, less than 100. Wow, very easy to give any dose to any patient. It again features exercise detection. Suppose you are exercising, it can predict and it can then automatically stop its functioning. So 94% reduction in hypoglycemia. It can personalize, it is tailored for teens, and it can reduce HbA1c in trials. Time in range is also improved, and zero severe hypoglycemia because it is smart insulin. It is adaptive. Now again, taking a case of a 45-year-old businesswoman from Mumbai, type 2 diabetes, 8 years, insulin neo due to injection phobia, HbA1c of 9.8. Many patients are like this in our day-to-day OPD. How this predict, prevent and personalize will work if it comes. The protein oral delivery, 8 to 10% bioavailability is there. It mimics the physiological insulin action and successfully trialed in India in 300 patients across 6 centers, but not commercially available. It is hepatic targeted, 70% first pass liver metabolism, 67% less hypoglycemia versus subcutaneous. It is personalized, oral is in tablet form, room temperature stable, mealtime flexibility, app-based titration. So A1C comes down from 9.8 to 7.1. This is oral insulin. Again, the smart patch system. This is the third thing, which will be coming soon to the insulin dogma. It can predict, which is Intarsia's ITCA 650. It is an implantable device, 6-month continuous delivery by a single patch. So match size, implant is there, zero missed doses because it is already there. Cloud monitoring is there with the device because it is Bluetooth enabled and it communicates with your phone. It can give a steady state delivery, temperature stable, no user intervention because patient need not intervene in this. App driven auto adjustment, 89% time in range is achieved with this. Again, it can be personalized. There is a machine learning algorithm which actually personalizes this insulin based on the person or patient profile. So it adapts to its schedule. It knows when I am going to exercise, so it will put itself down. It knows when I am going to eat every day, and then it will trigger itself. So this is where it is really smart and personalized itself. Again, a dual hormone system. This is again a case. I will be showing you examples of all these, but I am showing use cases of these. So a dual hormone system, which will soon come. If it comes, a 52-year-old bank manager from Chennai, type 2 diabetes with hypoglycemic unawareness because he's so busy with his work, cardiac disease also. So this Zealand's dasiglucagon insulin combination, which is there and which is in trial, will be a boon because it will be releasing glucagon whenever the blood sugar level reaches below 70. So this will make insulin again smart by virtue of using this dasiglucagon. So it can prevent hypoglycemia, it will personalize because it will optimize the insulin glucagon ratio, it will maintain HbA1c at 7, there are zero hospitalization because we have glucagon in our hand right at the word go, and it restores the hypoglycemic awareness in that patient. The next thing which will be a revolution would be the cell-based therapy, which will be living insulin factories. So again, a fictitious case of a 23-year-old medical student from Delhi, type 1 diabetes with kidney concerns. So ViaCytes PEC is the name. I will show you how it works. It is a retrieval pouch of encapsulated stem cell islets. It provides natural glucose response. It works just like our pancreas. So it prevents the physiologic insulin, it gives the physiological insulin secretion, so it prevents the complication, it restores the C-peptide and glucagon, achieves 78% insulin independence in 1 year. Again, it has a regenerative potential, so adjustable cell loading, kidney protective C-peptide and immunosuppression free options are available to improve HbA1c and EGFR. So current versus future technologies, when we see based on the trial data which is available to us, less than 3% hypoglycemic risk, 84% time in range, 94% is the adherence rate, and 1,20,000 would be somewhere around the annual cost of the therapy right now. But it is a projection, it will go down as more and more people will be starting using it and it is marketed. Now again, this has a glucose binding domain, a modified insulin molecule to control the release, and a reversible binding, which gives it a dynamic binding and dynamic response. So this is how it looks like. There is an insulin backbone, then you have an insulin receptor. This is the code name, NNC2215 in open state, and when it is in low blood sugar, it closes. So it closes, and therefore the insulin is hidden. So it will not act. So this is how a smart insulin works in response to the blood glucose values. Now again, insulin, you see the traditional delivery, but when it is nanoprotein interaction, which is done, insulin loaded graphene material. So again, the future directions are to make it glucose responsive by the manner I have told you, or to have a oral delivery of insulin. So these two things make really smarter insulin for us to have. Again, this is a beautiful read, in situ development of self-healing injectable glucose and pH responsive electroconductive composite hydrogel. They are using it for various molecules, not only insulin, but they have been successful in using this for insulin. And they are actually using this hydrogel technique for insulin delivery. Again, glucose responsive insulin and delivery systems, innovation and translation. Again, in type 1 and advanced type 2 diabetes, where they require insulin injections, they are using a range of glucose responsive components that can undergo a conformational changes, just like I have shown you, to activate or deactivate the insulin. So overcoming the digestive barrier can be done by oral insulin. We have seen oral semaglutide, and days are not far when we will be having oral insulin with us. So the protease enzyme, we all know, is the culprit, and actually there is absorption barrier also. But if we can overcome this due to all these things, whatever happens to the peptide, if we can overcome just like we have done in oral semaglutide, then we can actually have an insulin which is oral tablet form, and that would be really easy for all our insulin phobic patients. Again, you can see this graph, oral versus injectable insulin. In trial data, it is doing really well. You can clearly see the fourth oral insulin, and it is mimicking the healthy natural insulin, which is second, the red one. So it is almost mimicking the natural insulin secretion, the oral one, and it works really wonderfully well under the trial. Again, what is the difference? I show in the next slide. This is a little cluttered. If you see the subcute insulin, when we give subcute insulin, there is a chance of hyperinsulinization. So it increases triglyceride, we all know, it increases bleeding time, and it increases D-dimer and fibrinogen if we hyperinsulinate our patient. So non-optimal glycemic control is the result, sometimes hemorrhage and hypercoagulability can occur. But in oral insulin, there is no hyperinsulinemia because it is again acting in a smart manner. So normal TG, normal bleeding time, and normal D-dimer and fibrinogen. So optimal glycemic control and normal outcome. Smart patch system. So it is a miniature pump which precise osmotic delivery of insulin, temperature stable insulin, Bluetooth connectivity for remote monitoring of the algorithm as well as the outcome. AI algorithm is there for this. Again, this is the way a patch will look. It will release glucose in response to, it will release insulin in response to the blood glucose values. This is how it will look like. Once the glucose level is high, it will release insulin, and once the glucose levels are normal, it will not be releasing any insulin into the body. It is an adhesive patch which monitors blood glucose, and in a way it releases, it is preloaded with insulin, so it releases insulin in response to the blood glucose. Again, this is the patch which I have shown you. This is the dual hormone system which I was talking about. This actually has glucagon as well as insulin in it. Coming to the cell-based therapy, the living insulin factories I was talking about, this has already been released, the stem cell-based therapy, which shows promise in treating high-risk type 1 diabetes. The PEC direct device is designed to provide a long-term stable source of insulin to regulate blood glucose. It included 10 adults with type 1 diabetes, decreases HbA1c by as much as 1.5, increased C-peptide levels, and it has proven a potential for the stem cell-based therapies. This is how it looks like. There are three forms, PEC direct, PEC NCAP, and PEC QT. The difference being one form has a immunosuppressive drug incorporated into it to prevent any rejection, whatever so can occur. Again, pancreatic islet transplantation, sites for the treatment of diabetes. This is it. So isolated islets of Langerhans have been transplanted or injected into the portal vein of the host. And what it has done, this was presented in ADA, mind you, 3 years back. This is a revelation. The one person was able to discontinue insulin after 200 days. The cells are allogenic recipient, they require immunosuppression. TIR rose from 40 to 81 and in the end at 99.9. This is again a review. These are projections for cost reduction, hospitalization, productivity gain and complication prevention. So the future is now. We should act and engage in trials. If it comes to us, we should educate ourselves and our patient regarding the future, whatever there. So we all know a lot has been done, but we need to do a lot more. We all know. And whatever the future will bring, it will undoubtedly make a huge difference in the lives of million people worldwide. Thank you.
Thank you, Dr. Bharat. That was a very nice presentation. So actually with the introduction of GRIs coming up as predicted, with no hypos and no hypers, actually it might throw out the insulin pumps which we have been using right now. And I think the TIR is also very good, more than 80%. Any questions?
How long do you think it will take for all of us to adopt to these? When will they be in the market, if we want to be too happy about it?
I see a time frame of once a thing is presented to ADA, it takes around 7 to 8 years to be in market. It was presented 3 years back, the stem cell therapy, so I am most enthusiastic about it in next, say, 2030, 2032. Oral insulin will come much sooner because we already have a peptide which we have oral with us. So I think 28, 29, I see we will be having some oral form of insulin with us. The rest, time will tell. Thank you.
Thank you. Thank you.